So before we get started today, I just want to start by acknowledging that the land that the University of Ottawa is on is the unceded territory of the Algonquin and Anishinaabe people, who have long been the guardians of our land. And I want to make this acknowledgement because I think it's important to root us and connect us with regards to the work that we're doing, and wanted to make that meaningful too, because I often think about Ottawa is such a beautiful place, and I feel very grateful to work and learn and have my family grow here. So just wanted to acknowledge that at the outset. Before starting today, I want to position myself as a researcher and clinician and acknowledge the power and privilege that I have as a white and settler Canadian in being able to do the work that I do. Every statistic I share and every data point, as an Indigenous elder recently reminded me, are little spirits. And so I don't want us to forget that in talking about the data today. And certainly the implications of the work is that hopefully this has an impact and implications for all little spirits who are so important to our country thriving. I will be coming into my second year here at the University of Ottawa. So for those of you who I haven't met, just to give a little background about myself and who I am, I completed my PhD in clinical psychology at York University in Toronto, and I subsequently spent 6 years in Calgary at the University of Calgary doing my postdoc and at the Alberta Children's Hospital. And then on the far right, this is the part of the journey that takes place at the University of Ottawa and at CHEO. Those are the beautiful fall colors in front of Vanier 2 falls ago, and my bike ride to work along the canal. And then at the bottom there, those are my 2 little spirits who really inspire the work that I do. So to give us a bit of a roadmap, I'm going to talk about why I study childhood adversity and why it's important. I'll discuss how childhood adversity is transmitted across generations. I'll talk about protective factors in the face of adversity, and then provide you with some examples of community projects that are really in the spirit of breaking cycles of adversity. So why do I study childhood adversity? Well, the true character of society is revealed in how it treats its children. And the reality is that in Canada, we could be doing better at that. So a report card from 2020 showed that in Canada, with regards to children's mental health and well-being, we score a dismal 31st out of 38 wealthy nations. And when you dig deeper into why our ranking is so poor, it has a lot to do with disparities in mental health and well-being that exist between children and youth in Canada, especially when we look at things that are quite concerning, like youth suicide. And we know that kids' mental health also declined during the pandemic and became even more problematic, to the point where we saw rates that were almost double those that we saw prior to the pandemic. We showed that in a large meta-analysis of studies that was done on kids' mental health. And so what this tells us is that before the pandemic, there were quite significant problems with regards to children's mental health and well-being. And now in a post-pandemic world, this is really something that should be at the forefront of our minds. So why aren't the kids doing well? Well, there are many reasons for this. And Children First Canada put out a report that highlighted the top 10 threats to Canadian children. And among these are several childhood adversities like child abuse, poverty, food insecurity, systemic racism, and bullying. And one that I tend to focus on in my work is regards to child abuse and maltreatment, but increasingly broadening in terms of those adversities. And so these are really important to talk about because they're what actively contributes to children having difficulty. In UNICEF's most recent report card, which was just last year, actually that report card was on childhood poverty and showing that in Canada, childhood poverty is in fact on the rise, especially now that we don't have the subsidies that we had previously during COVID. And so 1 in 5 kids is actually facing barriers to having their basic needs met, like stable housing, nutritious food, and experiencing a lack of opportunity. And I recently had the opportunity to meet with some folks at Ottawa Public Health, and this is a really significant concern, and so is the housing crisis for children. So although these experiences of adversity are common, it's really important to note that these experiences cluster together and that they occur in the presence of equity stratifiers like income, education, gender, age, race, and ethnicity. So we don't see an equal distribution of these adversities for all children in Canada. What you see here is our adversities that are found in the tree. So those are things that happen at the household level. And then the roots of the tree are found within a community. And then it's important to focus on some of the adversities kids are facing in the broader environment. And I think, especially as we see climate change and an increase in natural disasters, these are increasingly adversities that kids are facing. So childhood adversity, it's an intersectional experience. And by that, I mean it happens at the intersection of different stratifiers and identities. And the layering of these different equity stratifiers contributes to long-term health and mental health. And just an example of this and the unequal distribution of adversities is recently I heard Dr. Chris Musquash from Lakehead University talking about a study he published that actually showed in the general population, we're seeing a decline in exposure to adversity for children, but among Indigenous children and youth, we're actually seeing an increase. This is concerning and something for us certainly to pay attention to. So why does this all matter? Well, exposure to these adversities, especially to child maltreatment, is associated with poor health and mental health across the life course. So childhood adversity accounts for 32% of attributable risk for psychiatric disorders. So it really puts us at risk of poor health and mental health. But we should also focus on this because it makes good economic sense. So a 10% reduction in these early adversities would result in an annual savings of $56 billion in North America. So it also makes good financial sense for us to address these. In our research group, what we're really interested in knowing about and studying are why some children flourish while others struggle in the face of significant adversity. Because what I hope I'll highlight for you today is that actually exposure to these circumstances is not deterministic. And there are many opportunities over the course of development where these types of experiences and sometimes the poor outcomes that we see can be disrupted. A couple of important things to think about before we dive into some examples from the research that our group has done is that certainly children's well-being occurs not in a vacuum, but in the context of systems. So we have to always be thinking about children being within families, within communities, and within a broader society. Additionally, we have to think about multiple generations. So many people have probably heard of the concept of intergenerational trauma or the idea of experiences that we have getting under the skin and being carried across generations. And so it's not just about what happened, for example, childhood adversity that happens to one child, but how that may be transmitted by both biologically and socially over time. And then finally, as I mentioned, that there are multiple opportunities where we can intervene and disrupt some of these cascades and some of these events from occurring. And I'll provide you with some of those examples through this talk. So how is childhood adversity transmitted across generations? So as I was mentioning, there is a lot of research that focuses on the direct effect of early childhood adversity on health and mental health for children and adults. And this is just an example of a summary of studies showing the effect sizes. Each one of those little dots represents a study, and these are odds ratios, basically showing the impact of early childhood adversity on child's physical and behavioral health, as well as adult physical and behavioral health. So we have a lot of research documenting this, and some may argue actually we maybe have enough research. documenting this at this point. But only in the last decade or so have people started to focus more on transmission and the intergenerational effects of exposure to adversity. And this is a slide taken from a paper from Claudia Boos and colleagues, where it's a theoretical paper where they're talking about how exposure to child maltreatment for the mother in childhood may be transmitted to her offspring prenatally, and the impact that those experiences may have on fetal or prenatal brain development. Now, I'm not a geneticist or biological scientist, but what I am really interested in is early child development and the postnatal environment, and the role that this might have in the experiences that kids have, and how those may play a role in transmission of early childhood adversity. So I'm going to share with you some work that I did with some colleagues with a large longitudinal cohort out of Calgary, Alberta, called the All Our Families Study. And this is a cohort of 2,000 women who were recruited in pregnancy and completed questionnaires twice in pregnancy, and they've since been followed when their children were 2 months, 6 months, 12 months, 2 years, 3 years, 5 years, 8 years. And now the kids are 13, and we're actually doing surveys with the youth. So it's an intergenerational cohort now, which is really interesting and provides lots of opportunity for interesting questions. This sample of women is representative of those found in an urban center in Western Canada. It is not an at-risk sample. And so, although there is diversity both from a racial and ethnic perspective, most of the women in this cohort are well educated and would be middle income. In terms of the methods, so mothers reported on their exposure to maternal childhood adversity, including things like abuse, so physical, sexual, and emotional abuse, as well as household dysfunction when they were young. So things like having a parent with a substance use issue, parent with severe mental health problem, or loss of a parent or parent who was incarcerated. When moms were pregnant, we asked them about the psychosocial risk that they were facing. So things like having low income, as well as things like having low social support and their mental health. We asked about their health risks, and this was actually taken from their health records that we were linked to. So this would have just been, say, for example, if they had hypertension or preeclampsia, we had a cumulative score of this. As well as after they had given birth, from their health record, we had a cumulative score of infant health risks. So things like being low birth weight, premature, an NICU stay, etc. At 4 months, we again had a sense of mom's psychosocial risk, like levels of social support, stress, anxiety, depression. And at 12 months, we had mom self-report on her child's development using the Ages and Stages questionnaire, which is a really common measure of children's developmental milestones. We analyzed the data using path analysis, so to kind of look at different direct and indirect effects in how maternal adversity predicted infant development, so her child's outcomes, through a number of different pathways. And what I'll do is I'll break this down in a little bit more simplistic way to talk about some of the indirect effects that we found. So we found evidence of a biological pathway whereby moms who had higher adversity in their own childhoods were more likely to have increased biological risk in pregnancy, which was subsequently associated with higher risk for infant health difficulties at birth, and then predicted poor infant development outcomes. We also found evidence for an indirect psychosocial pathway whereby moms who had higher adversity in their own childhoods had higher cumulative psychosocial risks, so were more likely to have mental health difficulties, stress, and low social support in their pregnancies. That was associated with moms having more hostile and challenging parenting behaviors, which was subsequently associated with poor infant development. And after we accounted for these two pathways, we no longer saw a direct effect between mom's own experiences of adversity and her child's development. So what this tells us is that, there are multiple and many complex processes by which maternal adversity from childhood then goes on to impact her child's development from an intergenerational perspective. So we found evidence of two intermediary pathways. We found that equity stratifiers in pregnancy were an important mechanism. So things like having low social support, mental health, low income, and that parenting behavior, because it was part of the psychosocial pathway, may actually be an important intervention target in the postpartum period. Following that study, we actually conducted a meta-analysis to look at not just our study, but since then, many of the studies that have focused on intergenerational risk. And what we found is when we're just looking at the impact of parental early adversity and children's mental health outcomes, we see a small but present direct effect. And what this tells us, though, because that effect is small, is that looking at those mechanisms and those intermediary ways that may be along the pathway is really important, and that it's having these experiences is not deterministic and there are multiple opportunities to intervene. So I think a key takeaway from that is when we're thinking about the impact of adversity across generations, that certainly there comes a time where we need to not just to look at what are the outcomes that we're seeing in kids, but we need to go a little bit upstream. And so that's why next I'm going to talk about protective factors that can disrupt some of these pathways in the face of childhood adversity. So I think I had showed this slide before, but basically it's the idea that if a mom who is, here at the beginning experiences childhood adversity, there are many opportunities, right? There's opportunities before pregnancy, opportunities in the postpartum, opportunities during parenting, and then opportunities for a child who is the parent of someone who has experienced adversity and ways in which we can intervene. And some of these ways may involve, a traditional intervention or a program, but as Anne Maston says, they can also be the ordinary magic or just the drip, drip, drip of everyday life. And so they can be things that occur at an individual level. So oftentimes, we'll talk about some of the individual characteristics that kids have that can promote better than expected outcomes in the face of adversity. But they can also be things at the family level, like family support, the caregiver-child relationship, or even things at a broader level like community efficacy or peer relationships. So an interesting question that we had in the context of the All Our Families cohort that I was just telling you about was, do child protective factors mitigate the intergenerational transmission of adversity or maltreatment for children's mental health outcomes? And so a postdoc that I was co-supervising in my lab, Jessica Turgeon, who's now at Université du Québec en Outaouais, tested this. So she looked at those maternal childhood adversities that I previously talked about. And then she also looked at protective factors that the child had. So things like ability to access support within their own family, whether they had good emotion regulation skills and ability to return to baseline in moments of stress. Those were all protective factors as measured from the BASC. They actually have a measure called the resilience subscale, but I find resilience is an outcome and a process. So I find using the word protective factors is better. And then when the kids were 10 and a half years of age, we have maternal reports of kids internalizing symptoms. So things like depression and anxiety symptoms. And what Jessica found is that for children who had high levels of perceived protective factors, there was no association between maternal adverse childhood experiences and children's depression and anxiety symptoms. Whereas for kids who had low protective factors, that wasn't the case. Actually, there was a stronger association. So what we find here is that when kids have the support and the skills that can be helpful to them, we actually don't see that maternal adverse childhood experiences has an impact on children's mental health outcomes in childhood. Another study where we were really interested in looking at the impact of protective factors and how they can be helpful for children is one called the SOAR study, which is a project that I was involved in at the University of Calgary and the Alberta Children's Hospital, and specifically at one of the child advocacy centers there. So what we were really interested in looking at is, did we see buffering effects of protective factors in children when they had experienced actually quite significant and quite high levels of childhood adversity, mainly maltreatment and abuse. So in this study, this was a case file review of 176 children who were referred to a child advocacy center for the most severe forms of abuse and maltreatment. So I think about nearly 70% of kids had experienced sexual abuse, and the majority had exposure to cumulative adversities, so multiple forms of maltreatment and also household challenges. So within this retrospective file review, we had researchers go through files and extract data. This can be a trauma-informed way of doing research in this population because we're not asking anybody to re-report information that they've already provided as part of a clinical service. And so we extracted information about the adversities they had experienced in their childhood. And then we also extracted to what extent certain protective factors were present based on the Child and Youth Resilience Measure developed by Michael Unger and colleagues. So this taps into to what extent kids have adequate and developed personal skills that could be useful to them, if they receive good peer support, if they have good social skills, whether or not they receive adequate physical caregiving from their caregiver and emotional support, and then also whether or not they have positive support from a spiritual aspect of their life within the education system or from a cultural component. We also looked at whether kids had certain symptoms present that are representative of post-traumatic stress disorder. And these are all the symptoms here, and our outcome was a cumulative score. As I mentioned, the majority of kids here are female. We have a good, I think, representative perspective in terms of race and ethnicity, and the mean age of children was about 10 years of age. What we see here is the kids in this sample had actually experienced, so these are not mutually exclusive, so many of them had experienced several forms of childhood adversity and were also very likely to be experiencing problematic symptoms related to their adversity exposure. We also saw that about over 60% had 4 or more adversities. Girls were more likely to have some of these adversities than boys, and the trauma symptoms really varied by age. When we looked at the protective factors, interestingly, many of them, it was a crude measure, right, present or absent, but many of them actually had these protective factors present. And so the kids who we're really worried about are those who didn't. And what we found when we looked at our analyses, a moderation analysis, was that we did see a moderating effect of protective factors on the impact of both child maltreatment and household dysfunction on cumulative trauma symptoms. So what this means is, in the presence of high levels of protective factors, we saw dampened effects of adversity on children's symptoms. So we see here that protective factors are important for interrupting the impact of adversity on trauma symptoms and can also break intergenerational cycles of adversity. So moving on to talk about some of the community projects. Some have argued or talked about whether or not childhood adversity research is translational enough. And this is a paper by Nicolas Berthelot, where he looked at this question. And what he found was there is an overrepresentation of research that's focused on the damaging consequences of childhood adversity. Fewer studies, only 19%, really look at the mechanisms that I was talking about earlier in this presentation. And then only 6% of the research focuses in on treatments, and even less than that focuses on preventive interventions. And so this is kind of a backwards way of doing things, because if we want to be able to actually have impact and improve the situation for children and youth, we need to boost the focus on treatments and also on preventive interventions. So how do we do this? How do we do this as researchers? Well, we need to step outside the academic silo, work with community partners, engage with individuals with lived experience, and also talk to individuals who are in community and who are working to impact policy and practice. So that's what we've been trying to do with some of these projects, and I'll give you some examples. So these are the projects that I'll talk a little bit about that represent opportunities to break cycles of adversity. So the first I'll talk to you about is Breaking the Cycle project, or what we call the Early Relationship Study. I'll tell you a little bit about Make the Connection, which is an intervention for parents of children 0 to 3. And then there are 2 projects called COPE and one called Into the Wild that occur at the level of children who are facing adversity. So the Early Relationship Study is one that we're doing in collaboration with multiple institutions, but importantly with our community partners, Breaking the Cycle and Max Right. Both of these programs they serve substance-involved mothers who are pregnant or parenting and are trying to make a change with regards to their substance use and improve the parent-child relationship. And our work with these 2 organizations is focused on understanding how these changes that occur in the context of the intervention have positive implications for their child's development and well-being. All of the mothers at Breaking the Cycle and at Maxine Wright have experienced early childhood adversity, and most have experienced severe forms and forms that many of us actually couldn't quite imagine, because using substances in pregnancy, postpartum, and as part of parenting is strongly associated with having these traumatic exposures and is often a coping mechanism. For this project, what we really hypothesize is that we'll be evaluating changes in maternal substance use, maternal mental health, maternal social support and stress, and also changes in the mother-child relationship, which we call the engine of development, as a result of these programs that we think will be associated with improved infant health and mental health. So this is our project. It's a longitudinal one, and we're just in the process of data collection now. I think we have about nearly 10 mothers at Breaking the Cycle and about 15 at Max Right who were recruited into the study and who are following longitudinally, and we aim to have 50 at each site. And so I hope from this project that we'll be able to demonstrate some of the important ways that both the intervention, but also changes that mothers make themselves, has a positive impact for their children. Moving on to Make the Connection, rather than focusing on a very specific population like substance-involved mothers, this project is focused on the broader population and getting an intervention out to parents that focuses on the parent-child relationship and how that can really be protective and can support the development of children despite parents having their own histories of maltreatment. And so this is randomized waitlist control trial where, through early on centers and different public health organizations in Ontario, parents are completing an online intervention, and we're looking at the implications of the intervention for maternal mental health, as well as the parent-child relationship and perceived bond between parents and their children. Moving on to some that are more focused on children. So first we have the COPE study, which is, we know that oftentimes caregivers can feel really lost when their first child experiences trauma. And so this is an online intervention that's designed specifically for caregivers to provide them with information about how to best support their child having had these experiences. And it's delivered while they're waiting to receive services, because we know that during the pandemic and beyond, wait lists for children's mental health services have ballooned. And so this is really an attempt to address that. Finally, as part of my role at CHIO and in collaboration with Sue Bennett, who is a pediatrician and a social pediatrician at the Vanier Social Pediatrics Hub, this past summer, we evaluated a summer camp that was happening at the Canadian Museum of Nature for 32 kids from the Vanier Social Pediatrics Hub, which is actually a hub where kids are referred who have emotional, social, and behavioral challenges from an underserved neighborhood in Ottawa. And the idea was that kids were kind of prescribed to receive this intervention, and we looked at the impacts, and several students actually in my lab were really integral in attending the camp and evaluating it. And that's a picture of us there, actually all up in Gatineau, where the camp occurred. Some preliminary findings from this research that are actually under review are that we did a mixed method study. So we had looked at quantitative outcomes where we found that kids' well-being, their social contact, and positive emotional state improved. And also through qualitative interviews with the kids, we learned a lot about the different beneficial aspects that they found. And this is just a quote from one of the kids where the researcher asked, "Has anything changed for you since coming to the camp?" And the child said, "No, just my identity," which I think as adults we found kind of funny. We said, "Well, what changed about your identity?" And they said, "I'm no longer that kid who stays at home a lot." And so this is the idea that something that attending a nature camp, but really it could be any kind of social experience that brings meaning, social connectedness, can be opportunities to break cycles of adversity and promote well-being in children and youth. So to wrap things up, addressing mental health implications of childhood adversity is really multifaceted. We have to think about the social ecology, the numerous pathways and prevention opportunities that exist, the important opportunities that exist with disrupting intergenerational effects and going upstream so that these effects aren't transmitted over time. All of this work is done in collaboration with some wonderful colleagues, and also the engine for the work, my lab, and all of its members and students and graduate students. And I'm incredibly grateful for their passion and dedication to the work that allows us to do all of this together. And I think with that, I will stop sharing my screen and open it up for questions.